2. I'm talking of type 2 because if you talk about type 1, the pathophysiology mainly involves two. One is autoimmunity and the other is idiopathic. Idiopathic means unknown. But if we're talking about type 2 diabetes, there are several pathophysiology and these are the following. Okay? Number 1, di ba I told you that there is incretin effect? If you have a decreased incretin effect, what will happen? There will be less insulin secretion. Therefore, we need to. That's one pathophysiology. Another pathophysiology. If you have insulin resistance, your body, your adipose tissue and muscles cannot receive glucose. So they don't have energy, correct? So they use fatty acids in the form to make it to have the energy. So there will be increase in the lipolysis. The breakdown of lipolysis will release free fatty acids. Okay? And then the free fatty acids have two major causes for hyperglycemia. One, gluconeogenesis, very good. And the other one is promote further insulin resistance. If you have higher free fatty acids in the body, the higher the insulin resistance. And of course, you know very well that free fatty acids are substrate for gluconeogenesis, which leads to hyperglycemia. Third pathophysiology. In our kidneys, there is SGLT2. Okay? It is located at the proximal convoluted tubules. Okay? The SGLT2 is the one responsible for absorption of glucose in the proximal convoluted tubules. Okay? So, if you have too much absorption of your glucose in the PCT or proximal convoluted tubules, this will go back to circulation. You will have hyperglycemia. Later on, in the pharmacology of therapies for diabetes type 2, there is an agent that inhibits the SGLT2. Inhibits so that the absorption of glucose will not be facilitated. And therefore, the glucose will be thrown out in the urine instead of being reabsorbed. So you will not have hyperglycemia, correct? Okay, next pathophysiology, decreased glucose uptake. This is more of insulin resistance. So the defect is in the insulin receptor in the adipose tissue and muscle cell. So if the adipose tissue and muscle cells cannot accommodate glucose to enter the cell, therefore it will accumulate in the circulation and will lead to hyperglycemia. Of course, if you have problem with your neurotransmitter dysfunction, if you have problem with your neurotransmitter, the problem will be your satiety. So you will have a voracious appetite. You keep on eating and eating, and the result is hyperglycemia. Okay? Now, you have your liver. If you have increase in hepatic glucose production, so what happens? So, if your muscles and adipose tissue cannot receive glucose because of insulin resistance, this organ will transmit information to the liver that you have to produce glucose for me because I'm hungry. Okay, so the tendency of the liver is to promote gluconeogenesis and degrade glycogen into glycogenolysis to produce glucose. If the liver do that, you will have hyperglycemia. Of course, if you have defective beta cell secretion, there will be less insulin and you will have hyperglycemia. In the presence of beta cell deficiency, the alpha cell gets activated. So the alpha cell secretes and releases glucagon. So what happens? If you have increased glucagon, there is increased gluconeogenesis. And therefore, you will have hyperglycemia. You remember this pathophysiology because different drugs for the treatment of diabetes type 2 will act on this pathophysiology to control the hyperglycemia. Okay? You get it? So, in your horizons, you have several risk factors for diabetes. Okay? Of course, those have a family history for diabetes, particularly those parents, those with siblings with diabetes, is at higher risk for development of DM type 2 later on. Okay? If you have overweight, okay, overweight in Asia is more than 24.9 body mass index. So that's a risk factor for diabetes. If you are African American, Latino, Native American, Asian, you have a higher risk for diabetes. Why? Of course, ethnicity and race is a factor, but what's another factor? What's with this country? The diet. Because, if you go to these countries, the unlimited soft drinks, coming along with big burgers and big French fries is really out in the market. So you can drive through there, and the drinks is unlimited. Okay? So you just get, for example, in America, you just have to pay like $12 for unlimited soft drinks and big burger and a big fries. So you stay there, you drink all you can. Okay, you just go to the soft drinks machine. So the big factor is not only the ethnicity, but of course the lifestyle there. Okay, of course, in patients who have previously impaired fasting glucose, which means borderline, they are not diabetic yet, but they have impaired fasting glucose or an HbA1c between this level, you are at risk for development of type 2. Siyempre, if you are borderline, if you don't take care of it well, the borderline will become overt. Parang mild, moderate, and then severe. Okay? If your patient had history of gestational diabetes, GDM is pregnancy, the development of diabetes during pregnancy. Okay? If you have a history that you deliver a baby more than 9 pounds, that's a risk factor for diabetes type 2. Anybody who has hypertension, anybody who have low cholesterol and a high triglycerides are at risk for type 2. Anybody who have polycystic ovarian syndrome, those people who are overweight, those who have acanthosis nigricans in the name of and then they have irregular menses, they have hirsutism, so PCOS is a risk factor for type 2 diabetes. And of course, any history of cardiovascular disease. So, you have to know this because if I ask you in the exam, which of the following is a risk factor for diabetes, the answer will be anything from here. I can ask around anything from here. Or, the following are risk factors for diabetes type 2 except. So it depends. So you have to know this. Okay? So, this is the spectrum of glucose homeostasis. Please remember the different normal values in each category. Remember, a normal fasting blood sugar is less than 100. We go for the milligrams per deciliter, never mind the minimals. Okay? We go for the milligrams per deciliter. So the normal fasting glucose should be less than 100. The normal 2 hours postprandial, which means after eating, 2 hours after eating, it should be less than 140. The normal HbA1c is a 3 months average blood sugar. The normal is less than 5.6. If we're talking about pre-diabetes or borderline, the fasting blood sugar is between 100 to 125. The 2 hours postprandial is 140 to 199, and the average is 5.7 to 6.4. Now, this is the criteria for diabetes. Fasting blood sugar of 126 or greater than, postprandial 2 hours of 200 or greater than, and an HbA1c of 6.5 or greater than. Please memorize this one. I usually ask, which of the following patient has diabetes type 2? And then I will have choices of the results. Okay, so you have to memorize. Let me emphasize that a single fasting blood sugar of 126 is not yet diabetes. It has to be 2 consecutive or 2 separate times. So before you would believe diabetes, you should have at least 2 126 and above fasting blood sugar on a separate occasion. Okay? Hindi lang single, 2. But the rest, that's fine. You can have diabetes with that single value only. Okay? You get it? Now, the importance of this one is that type 1 diabetes needs insulin for survival because they don't have insulin. Okay? The manifestation of a patient with TM type 1 without insulin is what? Diabetic ketoacidosis. Okay? That's why when you see babies, when you see kids, they have type 1 and then they miss the insulin injection, even just for 1 day. The next day, they will develop diabetic ketoacidosis. In type 2, it's different. Type 2 may not require insulin or just be on tablet. It depends on the scenario. Gestational diabetes is diabetes during pregnancy. They may require insulin or they may just require diet or even tablet. Okay? Okay. So these are the classification of your diabetes. This is in your Harrison. Type 1 is because of beta cell destruction leading to absolute insulin deficiency. And the cause is autoimmune, which means the body produces antibody against the beta cells, or unknown, or idiopathic. Okay? Type 2, I already mentioned to you the different pathophysiology. Okay? Other specific types, these are my favorite questions in the exam. So you have to memorize this one. Okay? So, the other specific types that we classify into genetic defects of beta cell development or genetic defects in insulin action. Take note. If I ask you in the exam, the following is genetic defects of beta cell development, the answer should be anywhere from here. Which of the following is diabetes that results from genetic defects in insulin action? The answers are here. One more. Can you see this? Mostly 1, 2, 3, 4, 5, 6. You see that? You have to memorize genetic mutation beside the motive. Example, what is which of the following diabetes types, the following diabetes results from mutation from glucokinase? The answer is OD2. Okay? If I ask you which of the following results from mutation of NeuroD1, you will have to memorize that MOD1 to MOD6. Plus, the different examples of diabetes from genetic defects of beta cell development or function or versus genetic defects in insulin action. You have to memorize. Okay? Lalabas yan for sure. Okay? So there are other causes. If you have problems in your exocrine pancreas, like for example, you develop pancreatitis, you may develop secondary diabetes. If there is a tantamount amount of pancreas removed from the body, or you undergo pancreatectomy, particularly more than 50% of the pancreas removed, you may develop diabetes. We call it secondary diabetes. Okay? Of course, other endocrine problems. Okay, you analyze. Anybody with excess growth hormones or acromegaly may develop secondary diabetes. Why is it so? Because if you have an excess growth hormones, the growth hormones causes gluconeogenesis and a little bit of glycogenolysis. Okay? If you have too much of that hormones, you have too much gluconeogenesis, correct? Okay. How about Cushing? What is in excess of Cushing? What? Cortisol. What does your cortisol do to increase blood sugar? Gluconeogenesis, and it promotes deficiency or defect in insulin secretion. It promotes also insulin resistance. Okay? Glucagon, glucokinoma. Of course, gluconeogenesis. So too much of glucagon in the glucagon-producing tumor can result to secondary diabetes. Okay. Pheochromocytoma. Catecholamines. What does your catecholamine do for the sugar? Increase gluconeogenesis. So you see, anything in excess, okay, of these hormones that promote gluconeogenesis may result to secondary diabetes. How about hyperthyroidism?
Chronic kidney disease.
What?
It's kidney disease.
Metabolism
Kidney
of what?
glomerulonephritis is different.
Gluconeogenesis ba? Anyone? Why do you think that in patients who have hyperthyroidism, they will also develop secondary diabetes? Anybody? What? Look, let me generalize it. Increase in what? So, if you have an increase in T4 and T3, gluconeogenesis? No. Insulin what? Resistance? No.
Repolymerization capacity को बढ़ाना है.
Anybody? Wala?
9 का folate deficiency होता है.
What?
Already लिखा हुआ है.
I heard the word catabolism. Catabolism of what? Hyperactive catabolism. So, insulin what? Can be produced. Okay? So if you have hyperthyroidism, there's increase in T4 and T3. The increased level of T4 and T3 hasten the catabolism of your insulin. Therefore, if there's too much degradation of insulin, you will have hyperglycemia. Correct? Okay, that's the pathophysiology of that one. What's the most common drugs that can cause hyperglycemia or secondary diabetes? Steroids. Okay, remember that one, huh? These viruses, these are the viruses that initiate the type 1 diabetes, the autoimmunity type 1 diabetes. I'll show you later the graph. In a newborn baby, they develop only type 1 once there is an immunologic trigger. The most common immunologic trigger for type 1 are your viruses. These are the viruses. Okay? These are not so common. Look at this, the syndrome. Okay? And of course, GDM is diabetes during pregnancy, which means after pregnancy, the GDM will disappear. Okay? This is the strict criteria for diagnosis of diabetes. Okay? Symptoms of diabetes: polyuria, polydipsia, polyphagia, weight loss, and nocturia. Okay? Very specific for diabetes. If your patient keeps on waking up in the bed from sleeping just to urinate more than 3 times at night time, that's particularly characteristic of diabetes. Okay? But they pee a lot. Because if your patient keeps on waking up but pee little, that's not diabetes. Okay? That's why. So these are the criteria. You have symptoms, plus when you get the blood sugar anytime, it's 200 or more. Okay? Or a fasting plasma glucose of 126 and above for 2 consecutive determinations. Or a single HbA1c of 6.5 or greater than. Or a 2-hour plasma glucose of 200 and above during an oral glucose tolerance test. An oral glucose tolerance test, your patient is being given 75 grams of a juice. And then, you get the blood sugar 2 hours after the juice. In a normal person, the glucose should normalize. But if it fails to normalize, you have diabetes. Okay? Okay, this is type 1. Okay? During birth, the beta cell mass is still intact. Okay? And talking about type 1, type 1. So the beta cell mass is intact. But you need somebody who has a genetic predisposition for diabetes type 1. And then suddenly, you need an immunologic trigger. What are those? The most common? What are the viruses? What is the other one? Kalimutan nyo kaagad. Remember that one, That will come out for sure. Okay. So in the presence of immunological trigger, there will be progressive destruction of the beta cell mass, which leads to the less production of insulin. Okay? If there is no already beta cell mass, this is zero, your patient will not develop diabetes. Okay? You will encounter that some type 1 diabetes does not only happen during 1 year old, 2 years old, 3 years old. Sometimes we encounter 15 years old, we encounter 18 years old, we encounter 21 years old. But they have type 1. They don't develop DKA because they still have a little of beta cell mass left. But there will be enough time that this will eventually be depleted and the patient will develop DKA. So always remember that one. Your type 1 diabetes patient should be on insulin. In just 24 hours without insulin, they develop DKA, which is an endocrine emergency. Okay? So these are the different agents used for diabetes. I will not go into dwell with this one because remember, I taught you this in pharmacology. So just a review. Your metformin, okay, is the most popular. It is the first line agent. Okay? The most common side effect of metformin is GI upset. Okay, it always comes out in the exam, right? But that will come in the exam next week. I always think that. But the life-threatening problem with metformin is lactic acidosis. How do you develop lactic acidosis? So, whenever you have a patient who is critically ill in the ICU with heart attack, with stroke, with sepsis, septic shock, hypoperfusion, never give metformin because your patient will die of lactic acidosis, which is really life-threatening. Okay, so never give metformin for those hospitalized patients that I've said, I mentioned. Okay, never give metformin for patients with more than 1.5 of CREA for men or more than 1.4 CREA for women. Okay, remember that. Your TBP, your alpha-glucosidase inhibitors is inhibit the absorption of glucose in the small intestine. Okay? These are the examples. Okay? The most common side effect is flatulence. DPP4, okay? Remember the GLP-1 I'm talking about a while ago? Your GLP-1 has a very short half-life. It's around like 1 to 3 minutes. Because they are being degraded by the enzyme dipeptidyl peptidase 4. So in just 1 to 3 minutes, they are degraded. This agent inhibits the DPP4 so that the GLP-1 will not be degraded that fast. So at least we have time for insulin secretion enough to lower down the blood sugar. These are the examples of DPP4 inhibitors. Please be familiar. I just want to emphasize that of all of these examples, your saxagliptin may increase risk of heart failure. If you have a patient with heart failure, never give saxagliptin because it will be more aggravated. Okay? The alarming side effect of DPP4 is pancreatitis. Okay? Next, insulfinuria. Remember the SU receptor in the beta cell? That's where your sulfonylureas act to promote insulin secretion. These are the examples. The most common effects are hypoglycemia and weight gain. Anything that promotes insulin secretion, anything that you administer with insulin can promote weight gain. Basically because your insulin is an anabolic hormone. Okay? Okay. This is this is my favorite agent of all. Okay? SGLT2 inhibitors. Remember, I told you that in the kidneys, in the proximal convoluted tubules, there is SGLT2 that promotes the absorption of glucose. This agent inhibits the SGLT2 so that there will be no reabsorption of glucose. And the glucose will be thrown out in the urine. Okay? So, these are the examples of SGLT2 inhibitors. Please know this by heart. This is a wonderful drug. I love this drug because it promotes weight loss. Which means if you have patients who have diabetes, who are overweight and obese, this is a very good agent to start with. Why does it promote weight loss? Gina? How does it promote weight loss? Anybody? What? So if you drop your glucose, hello, is this the person? Yes, what's your name?
सारी वीडियोस मैंने कपड़ों में सारी वीडियोस में करो ना करो
I heard him answer calories. If you throw out glucose in the urine, that's equivalent to calorie loss, and that will cause weight loss. But then, why are you ashamed? Why are you so? That your answer is correct. Okay? So if you throw out glucose, that's a loss of calorie in the body, and that's the reason why you have weight loss. Okay? But the problem with this agent is, since you are throwing out glucose in the urine, your patient is susceptible to develop urinary tract infection as well as fungal infection. Okay? Not everybody develops, but those patients who frequently, repeatedly develop infection, either UTI or fungal, you have to stop the SGLT2. I have some patients who develop fungal infection repeatedly. Their vagina, their penis becomes so itchy. So I have to stop it. And of course, shift it to another agent. Okay? But if there's none, this is a very good drug you have to continue. Okay? And then the next is thiazolidinedione. Okay? This is the example. There is no more rosiglitazone. Okay? What is left is pioglitazone. The problem with this agent are these side effects. It can cause increased fracture in patients who are post-menopausal. It may cause peripheral edema. It may cause congestive heart failure. It promotes weight gain. Okay? And it can cause macular edema. Because this agent causes water reabsorption. So you will have edema. So in patients who already have edema, if you have patient has anasarca, if your patient has congestive heart failure, never give thiazolidinedione. Okay, plus the fracture risk in patients who are post-menopausal. Okay, so amylin, let's go to this one. An example is pramlintide. Now, this is a GLP-1 receptor agonist, another favorite drug of mine, because it is a GLP-1. So which means it can promote insulin secretion. It can promote weight loss. Okay, it can promote weight loss. It's available in pen, but very expensive. So one pen to be used for 1 month will cost 8,000 to 9,000 pesos. But if you have a patient who have a very high blood sugar, who is obese, and your sugar is not controlled, starting with this agent is going to be very helpful to weight loss and reduce the hyperglycemia. It's just that very expensive. Okay? Even my very rich patient doesn't want to be on this one. I don't know why. They are rich, but they don't want to spend. Okay? So they are the ones who buy generic drugs. So that's funny. Okay? So it can promote weight loss. Okay? Of course, the most effective agent of all is insulin. If you remember, I told you what's the first line for treatment of type 2 diabetes? Metformin. That first line is neglected. If you have a patient who has weight loss, severe symptoms, and then when you get the blood sugar is 300 and above, you don't give metformin. Okay? The first line should be insulin. Okay? If I ask you, this patient presents with this one, weight loss, polyuria, polydipsia, nocturia, and you get the blood sugar is 350, what will you give? The answer is insulin. Lalabas na, promise. Okay? But in a different context. Let's see if you will remember. Okay? And of course, diet is important. Okay? A lot of patients will tell you that I'm not going to diet anymore because I'm treating already a medication. Okay? Diet is also important because no matter how you start on this medication, if your patient keeps on eating and eating, the sugar will not be controlled. Okay? So diet is very important. Okay, on your screen are the different classifications of your insulins. Okay? These from Harrison. These are the short-acting insulin. Okay? Please memorize. If I ask you an exam, which of the following is short-acting insulin? The answer will be anywhere from here. Short-acting means the duration is short, which means the manner of frequency for injection is how many? Looking at the duration, how frequent can you inject this in a day? Oh, gabi naman 6 times. 3 times before meals. Okay? Harrison committed mistake in the classification of insulin. Long-acting are only decimere and glargine. Okay? Remember that, I'm correcting Harrison. Because long-acting are only decimere and glargine. NPH is an intermediate acting insulin, not a long-acting. Promise. Okay? I'm giving up my license for this kind of argument. Okay? Remember, long-acting, decimere and glargine only. NPH is under intermediate. If you talk about long-acting, how frequent do you give it? Once a day. If you are talking about intermediate, which is NPH, twice a day. Okay? May correction of Harrison, remember? Okay? Okay. These are the insulin combinations. Okay? Insulin combinations are combinations of intermediate plus short-acting. For example, 70-30. What does it mean? 70% contains intermediate, 30% contains short-acting. That's how you know it, if you see 50-50. 50% intermediate, 50% short-acting. Okay? So, lalabas yan, will come out. Which of the following is an intermediate acting insulin? Okay? So, you have to remember that. Now, this is the reason why insulin has to be injected for specific numbers or frequency. For example, you give long-acting insulin. What's the frequency? Once. Okay? So if you inject it in the morning, the effect will be 24 hours. Look at this one. It's flat. Right? Flat. Which means, during eating or after eating, nobody covers for your sugar. You need an insulin that kicks in after eating. And that you need a regular or short-acting insulin. Okay? So, if you inject short-acting insulin breakfast, okay, that insulin will peaks and then goes down. At least it can lower down what you have eaten. Same with lunch, the same with supper or dinner. Okay? So, this is a very ideal combination of insulin, specifically for patients who are poorly controlled with diabetes. Okay? Okay. What did you give NPH? NPH is being given how frequent? Twice. Okay, so you give it the breakfast, you give it at dinner. Okay? So look at this one. Until before dinner in effect. And then dinner to breakfast. Okay? But again, you need the regular insulin to address the hyperglycemia after eating. May I ask, why is there no short-acting insulin at lunchtime? Can you see the short-acting? It's only being given breakfast and dinner. There's no lunchtime. Okay, very good. Look at your NPH. There is a peak, right? It peaks before lunch and therefore can take care of what you will be eating at lunchtime. Yan na siya, authentic na siya. So cover na siya ng FDA. Okay? So that's the mechanism for that one. Remember, I show you the pathophysiology, and the reason why I'm showing you that because there are agents that specifically act on that pathophysiology. For example, glucose reabsorption, you need SGLT2 inhibitors. Increased insulin resistance or glucose uptake and utilization in the muscles. These are the two agents that takes care of that. Increased free fatty acids or insulin resistance. These are taken care of by high-quality diet or pioneering. Okay? Decreased hepatic glucose output are taken care of these two agents. Okay? Your incretins stimulate insulin secretion. Your alpha glucosidase inhibits the absorption of glucose in the small intestine. Okay? Insulin secretion, these are the agents that promote insulin secretion. Okay? These are the agents that decreases your glucagon secretion. And these are the agents that controls your appetite. So if I ask you the exam, which of the following agents for diabetes
तब तक रुकेंगे तब ना
affects the appetite control? So either incretins or okay. Which of the following agents is an insulin secretagogue? So three. Urea, glutathione, and incretins. Okay? So remember this one, which of the following decreases the free fatty acids? Okay? I think I showed you this already during your pharmacology, just a review. Okay? I'm just going to highlight. Metformin should not be given for patients with a computed estimated GFR of less than 30 ml per minute. Otherwise, your patient will develop what? Renal failure, no. Lactic acidosis. Okay? The most common side effect of metformin, GI upset, but it will never come out in the exam. Okay? GLP-1 receptor agonist. Okay? These are the one expensive. Examples are your exenatide. Okay? Okay? Exenatide, liraglutide. Okay? It can promote weight loss. Okay? Okay. SGLT2 inhibitors can cause weight loss and urinary tract infection and genital nephrotic infection. Okay? Look at this one. It may cause diabetic ketoacidosis and various stress settings. Remember that one. If I ask which of the following agents may cause diabetic ketoacidosis, the answer is which are canagliflozin, dapagliflozin, or empagliflozin. Okay, remember that one, it will come out in the exam. Remember that one. Okay? Okay, next. DPP-4 inhibitor. All agents except linagliptin needs renal dose adjustment. If you use linagliptin, there's no need to reduce the dose. But in patients with renal failure, all of the SGLT2, DPP-4 inhibitors needs to be reduced. Okay? Except for linagliptin. Now, which of the DPP-4 inhibitors may cause heart failure? Saxagliptin. That will come out. Marami na you already have lots of bonus. Okay? Okay, next. Alpha glucosidase inhibitors, the most common side effect is flatulence. Thiazolidine diones or pioglitazone may cause weight gain. Okay? And may cause fracture risk. So it should not be given for patients who are post-menopausal. Okay? Okay. So urea, weight gain. Side effect, hypoglycemia. Okay? Insulin is the most effective drug. Okay? Pramlintide can cause also weight loss. So remember, Did you summarize it, ha? What are the following agents that may cause weight loss? GLP-1 receptor agonists, SGLT2 inhibitors, and pramlintide. Okay? Minimal for metformin. Very minimal. Okay? Which of the following agents may cause fracture? Isothione. Let me add. Your SGLT2 inhibitor may also increase risk for fracture. So there are two. SGLT2 inhibitor and BCD. Which of the following agent may cause macular edema? What? Macular edema, RA. The shy RA. Don't be shy, you're so handsome. Thiazolidine diol. Okay? Okay. Remember that one now. Which of the following may cause fungal infection? Which of the following can cause diabetic ketoacidosis? You already have like 20 points already. Okay. So, remember this one. Listen. During my school time, whenever the professor tells us, this will come out in the exam, we are hurriedly writing it with asterisks. Okay? So dapat you do the same. Whatever I said, that it will come out, it will really come out. Put an asterisk on that. Okay? Always do that. Always do that. When I was taking down notes. Okay? Remember this one. These are the treatment goals for patients with diabetes. Once you already have diabetes, your typical patient, you should have a goal. Okay? The HbA1c goal should be less than 7%. Remember that. The before breakfast sugar should be 80 to 130. The 2-hour postprandial should be less than 180. The ideal blood pressure should be less than 140 over 90. Okay? The LDL, which is the bad cholesterol, should be less than 100. The HDL, which is a good cholesterol, should be less than 40 for men, 50 for women. And the triglycerides should be less than 150. Remember this one. There are 2 to 3 questions from here. So if I ask you, the goal for lowering LDL cholesterol for patients with diabetes should be less than 100. Okay? Remember that one, that will surely come out. Okay? Okay, this is how you guidelines for comprehensive medical care. Okay? HbA1c is being requested every 3 months. Okay? Okay. You need education. Okay? For your patient. You need eye examination. Remember this one. If you have a patient you diagnose first time to be having DM type 2, you send them right away to ophthalmologist for eye examination for the possibility of retinopathy. Okay? But if your patient has type 1, okay, very good. You send your patient after 5 years being diagnosed with type 1. For children less than 10 years old, you do not expect them to develop complications yet. But for children with DM type 1 more than 10 years old, you have to anticipate the possible complications of diabetes. Okay? Okay. So, you screen for diabetic nephropathy by requesting for the, what do you request? The urine creatinine albumin ratio. Okay? Blood pressure, of course, you request for lipids. Remember this one. Listen, if I ask you, what are the vaccines that are very necessary for diabetic patients? The answers are influenza, pneumococcal, and hepatitis C. Remember that one? It will surely come out. You're very lucky. It's like I'm telling you everything. Okay? And of course, if patient has a risk for stroke or myocardial infarction, your patient at the age of more than 50 years old or with risk factors for cardiovascular disease should be started on aspirin. Okay? If there's no contraindication. Okay. So, remember this one also. These are the different complications of diabetes. These are classified as follows. Acute complications include DKA, hyperglycemic hyperosmolar state, and hypoglycemia. Okay? Macrovascular complications include heart attack, stroke, and peripheral arterial occlusive disease. Microvascular includes retinopathy, nephropathy, neuropathy. Okay? Of course, cataract, glaucoma, okay, hearing loss, etc. Okay, so if I ask you in the exam, which of the following is a microvascular complication? That's it. Myocardial infarction, cerebral infarct, erectile dysfunction, and peripheral arterial occlusive disease. Erectile dysfunction. Okay? I'm not going to say na retinopathy. I'm not going to say nephropathy. I'm going to say the specific clinical manifestation. Okay? Para hindi naman kayong so if I ask you the patient presents which of the following is a manifestation of macrovascular complications? A. Gastroparesis. B. Blurring of vision. 3. Cataract. 4. Non-healing ulcer. Okay. Non-healing ulcer can be a manifestation of peripheral arterial occlusive disease. That's how we make exam. Not really to give you like coronary heart disease, peripheral arterial occlusive disease. You have to think. Okay?